The following podcast is part of a certified educational activity titled Taking the Pulse of Undiagnosed Atrial Fibrillation. Pharmacists as a linchpin of detection and team-based care. Access the entire activity and complete the post-test at peerview.com/KMF860. Downloadable slides and practice aids are also available.
Hello, this is Barry Bileski from the University of New Mexico. Welcome to this educational activity focusing on taking a multidisciplinary and novel approaches to detecting atrial fibrillation in the community setting. Joining me in today's discussion are Joe Anderson and Avinash Ashrecker, who are also from the University of New Mexico. So let's begin. Dr. Ashrecker, tell us a little bit about what atrial fibrillation is and why are we here today talking about atrial fibrillation? Ash?
Great, thanks Barry. A little bit about atrial fibrillation. So atrial fibrillation is an abnormal heart rhythm. What we see here on the left side of the panel is normal sinus rhythm. Electricity is generated in the top part of the heart called the atrium, in the right atrium, and it proceeds down through the HAS bundle, which is kind of in the middle there. Then the ventricles, the big pumping chambers of the heart, then contract. You can see how it looks like on an EKG on the bottom there. But atrial fibrillation, it's a different beast. It's a very common arrhythmia, and we'll talk about some of the risk factors in a couple of moments here, but it's a chaotic, disorganized atrial electricity, as you can see there on the right panel. Some of that electricity gets into that HAS bundle, and then the ventricles subsequently contract, but they contract in an irregular fashion, and you can see that how that's represented in an EKG there. So how common is atrial fibrillation? It's very common. In fact, I've actually had atrial fibrillation myself many years ago in medical school. But it is a problem of aging. So in the United States, at least 3 to 6 million people have atrial fibrillation. And as we have an aging population, that number is going to increase to 6 to 16 million by the year 2050. There's increased rates of obesity, increasing average age are risk factors, as well as hypertension is a risk factor. This costs an immense amount of money per year, $6 to $26 billion to treat annually.
So one of the goals of this activity is to identify ways that pharmacists can work collaboratively with other clinical colleagues to really bridge the gap between patients and healthcare professionals to really improve AFib screening, diagnosis, and treatment. But Ash, why is it so important that we identify individuals with atrial fibrillation?
So atrial fibrillation or flutter, it's a similar rhythm. It's generated a little bit differently, but the risk factors that are the same are associated with increased rates of morbidity and mortality. So one thing is these rhythms, atrial fibrillation, can cause tachycardia or a fast heart rate, and that can be associated with ischemia, not enough blood flow to the heart muscle, or even heart failure, a weakening of the heart muscle and developing symptoms. Cardiovascular hospitalization increases 2 to 3-fold. Thromboembolism or stroke increases 5-fold depending on your risk factors. We'll talk about those later in the presentation. But death increases as well, a 2-fold increase in death. If we look at the right side of this panel, you'll see that women is in yellow, men are on the right. There's an increased cumulative stroke risk in women compared to men. And this is also delineated when we talk about a scoring for atrial fibrillation and the risk of stroke and systemic embolism. So atrial fibrillation prevalence increases with age. So as we have an aging population, we're seeing more atrial fibrillation. I did say that there's more stroke in women than men, but there's actually more men than women that have stroke. If you can see here, the black bars are men, the red bars are women. But as we know, women live longer than men, and so over time, there's a more accumulation of women that have the burden of living with atrial fibrillation than men.
So with such a significant risk in stroke, it seems that it would be very important to prevent and detect atrial fibrillation. Ash, what are potentially some of the risk factors and symptoms associated with atrial fibrillation?
Thanks for the question, Barry. Yeah, there's risk factors that have been really well defined from research models and historically. There's some that are non-modifiable, like age. We can't change your age, but there are modifiable risk factors to develop atrial fibrillation, as well as controlling some of the risk. Hypertension, high blood pressure, heart disease is a modifiable risk factor that can be treated. Heart failure, hyperthyroidism, excessive alcohol intake, obesity, and sleep apnea. Add diabetes to this as well. And that's a modifiable risk factor that can be treated. If we're talking about symptoms, the general patient, what are they feeling? The interesting thing about atrial fibrillation is you can feel a lot of things. You can feel palpitations, that's like kind of a fluttering or an accelerated or irregular heartbeat. You can have fatigue if your heart rate is fast or irregular. That could represent tiredness. You can faint. Usually this doesn't happen. It can happen in the elderly patient or those that have a corresponding significant heart disease. They can sometimes syncopize or faint. You can have dyspnea or shortness of breath at rest or with physical activity. Sometimes lightheadedness, this is pretty common. And then those that have coronary artery disease may not have good coronary perfusion during times of rapid tachycardia in atrial fibrillation, and they can actually have angina as well. But many patients are asymptomatic. I think I began saying, I had atrial fibrillation when I was in medical school, but I went hours and hours, probably a half a day in atrial fibrillation, not feeling it at all. And that's not very uncommon. AFib can have a triad of symptoms, which is the racing, fluttering heart, palpitations, shortness of breath, some lightheadedness and dizziness, but you can have no symptoms at all. There are some data to show that those in atrial fibrillation only know about half the time they're in atrial fibrillation. So you can't really ask a patient, do you feel it? Do you feel these palpitations? If they say no, that doesn't necessarily mean they don't have atrial fibrillation.
I think this is extremely important because, obviously if a patient comes to clinic or to the pharmacy, they're short of breath, dizzy, that could be atrial fibrillation. But as I was going to ask is, what about patients without symptoms? We know people with symptoms are at risk for, really stroke and potential death. But what about these asymptomatic patients?
That's a great question. It's really difficult to treat a patient that doesn't feel bad. Many patients say that I don't feel my AFib, I don't need to worry about it. But if you can see on the right side of this panel, this is a graph that shows symptomatic versus asymptomatic. Asymptomatic is in red. So patients with events is on the y-axis. And you can see there's actually a numerically higher increase in patients with events that are asymptomatic versus symptomatic. We should note that there's really no difference statistically between these two lines, which tells us whether you're symptomatic or asymptomatic, you are still risk of having cardiovascular events, stroke or systemic embolism.
Yikes, that is really not good news. Joe, how common is this asymptomatic or undetected atrial fibrillation?
Yeah, thanks, Barry. And as Ash mentioned, the risk of stroke in asymptomatic and symptomatic patients is about the same. So a lot of recent research is focused on trying to identify the rates of silent or asymptomatic atrial fibrillation. And estimates vary, but in general, from single time point screening in patients who are 65 or older, undiagnosed AFib is about 1.4%. More intensive screening programs, such as screening twice a day over a 2-week period, the incidence is slightly higher, around 3%. And I note our recent experience with both our opportunistic screenings at our student-driven health fairs and systematic screenings in community pharmacy settings were on the higher end. And this might be reflective of a higher risk population. And I would like to add that a recent study called the Vital AF was just recently published in a similar population, patients over the age of 65, but seen in a primary care clinic. And they utilized a single lead ECG screening or just usual care. And they found the incidence of asymptomatic AFib in the screening group to be about 1.7%, very consistent with previous studies, and versus 1.6% in usual care group, and usual care consisting of pulse palpation or auscultation.
So this asymptomatic or undetected atrial fibrillation seems to be, probably pretty important in managing atrial fibrillation. And it seems like we could be missing a lot of patients, diagnosing them with atrial fibrillation if they have no symptoms. How do we identify or catch these patients?
Yeah, thanks, Barry. And that's the big question: is how do we identify these individuals? And you could one of two methods. You can take a systematic approach to screening or an opportunistic approach to screening. And so in a systematic approach, you're taking a more targeted group, a higher risk population, and then screening those individuals. So those studies that I was mentioning, for example, they chose individuals who were over the age of 65. As Ash mentioned, the risk of AFib goes up with age. And then they also looked at, or you could target individuals with those risk factors for heart failure, such as hypertension, heart failure, diabetes, et cetera. So an opportunistic screening would be more like a health fair, where you screen all comers, regardless of risk. And so at that point in time, you're hopefully combining it with additional screening for risk factors such as high blood pressure, diabetes, et cetera. And this is an example that I alluded to earlier with an opportunistic screening that we've conducted at health fairs around our community. And we found in the general population that came to the screening about a 2.3% incidence of atrial fibrillation detected with our single lead ECG screening device. Looking at the higher risk patients, we saw the majority of these patients who were screened positive did have higher risk factors for stroke. And that's important. And that's why we were doing the screenings, because these are the individuals who are at higher risk then for stroke. As you know, in the old days, screening was not easily conducted. So if you were at a medical office, you had to have a 12-lead EKG. And so patients who perhaps with pulse palpation or auscultation were determined to possibly have atrial fibrillation, you would have to, if you had a 12-lead EKG in the office, perform that, or you would have to send them off to perhaps a hospital or another provider for the 12-lead EKG screening. Or for those individuals who you might suspect have a paroxysmal atrial fibrillation, you might have to hook them up to a Holter monitor for 24 or 48 hours. But with advances in technology, screening has become much more easy and efficient. We have a multitude of devices now that can be used for screening. Many people are familiar with the smartwatches that can be worn and used for screening for atrial fibrillation. There are advertisements on TV now for devices that individuals can purchase and screen themselves for ECGs. And so these various devices have differences in sensitivity and specificity for picking up atrial fibrillation. So Ash, is there anything that you think needs to be added here with regard to these various devices in terms of sensitivity and specificity?
Joe, thanks for your question. This is really important. As we've seen in the previous slides, there are new advances in how we can detect atrial fibrillation. It started with just palpating a pulse, to auscultating with a stethoscope, to these really cumbersome monitors that we could either do a point of time EKG, which is just about 5-10 seconds of time, or these bulky Holter monitors that we would have people wear for a day or two. The monitors that you can see here, there's many kind of monitors here, but the ideal method of screening has really high sensitivity as well as really high specificity. And if you look at pulse palpation, for example, there's 94% sensitivity. So this tells you that it's really good at ruling out if you don't have atrial fibrillation, but its specificity is only about 72%. It's really not great at ruling it in. That's because people mostly have paroxysmal atrial fibrillation and they're not always in it. But if you look at some of the other devices, we can look at the AliveCor Cardia heart monitor. You know, its specificity and sensitivity are much higher, and you can see all on down the line, we've really improved with specificity and sensitivity, and I think that's why it's probably a better way to start looking for atrial fibrillation in our community.
Thank you, Ash. Technology is certainly amazing, but Barry, is it reasonable to screen, and are there guidelines in regard to population screening for asymptomatic or undetected atrial fibrillation?
So when we think about population screening, we have to always balance risk to benefit and also feasibility. You know, for screening to be enabled to screen a population, it needs to be inexpensive, easy to use, high positive predictive value. And if we look at today, looking at to screen for atrial fibrillation with the devices available with the new technology, it really meets this criteria. It's less than $200. You can have the device. It's easy to use within 30 seconds. Anyone can do it. And as you and Ash pointed out, it works pretty well in detecting atrial fibrillation. So from that standpoint, either opportunistic or systematic screening is very much feasible. And are there positive outcomes? As Ash mentioned earlier, you have atrial fibrillation and you have risk factors. You're at risk, high risk for stroke. And so, and importantly, and luckily, we have very efficient, very good pharmacotherapeutic option anticoagulants that we can reduce our stroke risk and mortality. So from that positive outcome aspect, it is certainly something we want to consider to screen on a population basis. As with anything, there's always, you know, negative aspects to consider, but you always want to consider, are these acceptable outcomes? There is a cost. It's not free. There's time involved. You increase potentially patient stress, could increase office visits, overdiagnosis, potential for unnecessary diagnosis, diagnostic testing and treatment. And also, we don't yet have outcome data to show improved outcomes with population screening. Now, if we look at the guidelines, and we look at the guidelines here in the United States from the U.S. Preventative Service Task Force, they state that the current evidence is insufficient to assess the balance of benefits and harms of screening atrial fibrillation. But we also, in the guidelines, they also mention we still need to consider pulse palpitation to be part of routine or usual care. A couple of things to note here. In the review by the task force, it has to be noted that there was no eligible studies were found that evaluated harm in screening patients for AF as compared to no screening. And as importantly, as I mentioned earlier, we have no outcome data. And Joe has already talked about the VITAL AF, similar detection rate with two different types of usual care versus single lead ECG. But of note, in the usual care group, they did include automated devices, palpitation, and auscultation as detection devices. Look at other guidelines around the world. The European Society of Cardiology does recommend opportunistic AF screening by pulse assessment or by EEG rhythm strip in patients 65 years of age or older. Guidelines also note that the good setting for AFib screening include pharmacies and community screening at special events. We look at the Australian Heart Foundation. They have a similar sort of recommendation, opportunistic point of care screening in the clinic or community setting should be conducted in people aged 65 years or more. Now, as we have mentioned, patients with atrial fibrillation may have significant risk for stroke that can be prevented with anticoagulant therapy. Joe, how can we find these patients that, you know, may be asymptomatic, walk around with atrial fibrillation, don't know they have it, in a sustainable and, importantly, a portable approach?
Yeah, thanks, Barry. And that's a huge question. I would like to think that pharmacists are an answer. And pharmacists' role in this process depends on their location. So pharmacists who are in the community are an excellent source, excellent resource. They're everywhere. They're in rural, urban, underserved areas. It's said that 90% of our population lives within 5 miles of a community pharmacy, so we're accessible. And so the community pharmacist could be then used for a source of screening using the devices that we've mentioned through opportunistic screenings or even systematic screenings and targeting a higher risk patient population for screening. Pharmacists in the clinic setting working with other providers can be utilized to screen, but really to manage risk factors. So hopefully preventing the development of atrial fibrillation by better control of those risk factors. And then once a patient does develop atrial fibrillation and it requires anticoagulation, pharmacists are uniquely suited to run the anticoagulation clinics and control the levels of anticoagulation and avoid dangerous drug-drug interactions and other interactions with those agents. So we really believe that community pharmacies, there's a golden opportunity, and they are certainly an untapped resource with regard to screening for atrial fibrillation. As I mentioned, 90% of the population lives within 5 miles of a community pharmacy, and 90% of the population also visits a community pharmacy at least once a year. And so that's an opportunity at each of those visits to educate patients about the risks of atrial fibrillation, the risk and warning signs of stroke, for example, but also to screen for the asymptomatic atrial fibrillation. And so this is what we're really trying to approach, is getting community pharmacists more involved. To do that, we have to have a sustainable model that can overcome some of the barriers that would be seen in the pharmacy setting or even in the primary care setting. And so any kind of screening that would be done needs to be time efficient and labor efficient. There has to be a perceived value for the patient to undergo these screenings or want to seek out these screenings. There has to be a value for the pharmacist to provide these screenings. And really we want providers to see the value if a patient is screened in a pharmacy and comes into their office setting with a positive result. We want them to understand what that means and that they have to then, they should then pursue additional assessment of the atrial fibrillation. And then in terms of cost, it has to be at least cost neutral for pharmacies to be able to do the screenings. And so what we've taken, we would encourage community pharmacists to reach out to local colleges of pharmacy, maybe colleges of nursing, schools of medicine. Many of them have online training programs that they can utilize, that pharmacists can utilize for their staff. We have that training. We offer free CE training for pharmacy technicians as well as pharmacists. There's a lot of resources on the internet. The American Heart Association, for example, has numerous resources that individuals can go through and train on atrial fibrillation. And then what's really important for community pharmacists is to develop an efficient workflow pattern. We realize that pharmacies, pharmacists, pharmacy staff, they're very busy. We understand that. But the screening really only takes less than 1 minute. And so if it becomes part of the routine workflow, it really does add much additional time to their normal work. And so we would encourage pharmacy staff to be trained on how to screen. It could be a clerk, it could be a technician. If the pharmacy has an intern certainly can do the screenings. The pharmacists really just need to be engaged if there's a possible atrial fibrillation, in which they can talk to the patient and explain what atrial fibrillation is, what the risks are associated with atrial fibrillation, and then importantly, encouraging the patient to go see their primary care provider to be able to be tested for additional tests for atrial fibrillation, and then ultimately management of atrial fibrillation. And so, first and foremost, you have to have all your staff on board and trained with regard to screening for atrial fibrillation. And we would say you should really designate an AFib champion in your store. A person who's the go-to person for atrial fibrillation and can coordinate either these systematic screenings or the opportunistic screenings. And in terms of recruitment, patient recruitment, we would simply say, place signs around your pharmacy. We have signs we've created, that say takes 30 seconds to potentially save a life. That might capture a patient's attention, and they'll ask, what is this? What is this about? And then it's an opportunity to talk to them about the screening. If they're waiting for a prescription to be filled, screen them. Have your clerk or technician offer them some screening. And then it's important for community pharmacists to really partner with local primary care providers and talk to them about what it is you're doing, that you are periodically offering these screenings, and what it means when they get a positive. It's not a confirmation of atrial fibrillation. It's for them, the primary care provider, then to follow up and do additional testing to determine if there is atrial fibrillation or not, and then what therapies to initiate.
Joe, that's a really critical issue. You brought up, a real critical point there on establishing the collaboration with the local provider, especially in rural settings. Ash, can you talk a little bit more about this and how you see these collaborations perhaps coming together?
Yeah, thanks for the question. This is a team approach to this. This kind of testing in the community, screening in the community is very helpful as an initial step. But that's just the initial step. If atrial fibrillation is possibly found, collaboration with a general practitioner, a primary care provider, or even a specialist is essential. So those kind of collaborations need to begin before this screening. These screening processes begin in the community pharmacy. And I think Joe said it best. Collaboration with the School of Pharmacy or a School of Medicine is very helpful. That can be done telephonically, teleconsultation, even through telemedicine, but a collaboration needs to begin. So a patient, when screened in, has somewhere to go.
Thanks, Ash and Barry. The other point I would talk about is cost effectiveness with this model. And really, there is no model for reimbursement for doing these types of screenings, but it's really a value-added service that a pharmacy is providing to their patients. And because of that service, hopefully, it leads to retention of those patients as customers of theirs, as clients of theirs. And so, periodically offering these screenings, maybe 3-4 times a year, or as we mentioned, targeting more systematically, higher risk patients and offering those individual screenings. Again, that's cost effective, because if you can prevent one stroke, that more than pays for itself. And then another value that pharmacies can accrue with this service is medication adherence, educating the patients about the importance of anticoagulation therapy and making sure that they're adhering to their therapy. Patients who take their medications, the drugs become more effective, obviously, but they're also more reliable clients, and they come back to the pharmacy, as we mentioned, multiple times. The devices themselves are very, very reasonable, under $200 to purchase one of these devices and set up a screening service. So here at the University of New Mexico College of Pharmacy, we've taken many of these approaches and have developed a sustainable and portable model for population screening for AFib in the community setting. Barry, can you briefly describe this working model?
Oh, absolutely. So as Joe mentioned, one of the models we use is working in student-driven health fairs, and we'll talk a little bit at the end here about how to perhaps set that up. The other approach we have taken, and that the health fair is more opportunistic approach, we've taken a very much more systematic approach in the community pharmacy setting. In this setting, we've established our APPI students, our P4 pharmacy students, and have them screen for patients. We do it in a systematic way where we identify high-risk patients. based on age and medication profile, looking for cardiovascular type medications or diabetic type medication. We have the API students perform the assessment. Our next level is going to be teaching pharmacy techs to do this. And if no AF is reported, participants are counseled by the students on the results, and we provide education, and they're on their way. So the pharmacist, time efficient model. In this model, the pharmacist is not even involved in this process, so very efficient for the pharmacist. If AF is reported, then the patients are counseled by both the pharmacist and the student. We ask permission to call their primary care physician to discuss the results with them and ideally set up an appointment. If patients don't want to do that, we give them a Dear Doctor card, and I'll show you an example of that in the next few slides, explain the results. And we counsel the patient on atrial fibrillation and stroke in general. And we do this with American Heart Association flyer. And importantly, anyone that we screen, we provide this AFib stroke education because we think it's important to provide the community avenue for stroke education and to promote stroke education and understanding the risk for stroke and the signs and symptoms for stroke. Now, our model, so we train our students, we train the pharmacists in the community settings that we're reaching out to. We have online module training videos, competency exams, hands-on training. As Joe mentioned earlier, we provide CE not only for pharmacists, but potentially pharmacy technicians who are interested. And you can see there how to log on. And you're more than welcome to take the course and get CE credit for that. There's no charge for this. For our API students, it's a requirement. It's part of their API rotation. They have to do these assessments. Similar to medication adherence calls, patient counseling, it's part of the API experience. Data is reported back to the faculty champion to our experiential office, and we provide the equipment, screen, forms, signage, and documents, all provided by the college. We use the Cardia mobile device, as you see here. Again, 30 seconds, we have a rhythm strip, and we have an answer with that. Very efficient, easy to use. Patients think it's kind of interesting. Here's our data collection form. You can see here, you can read this yourself. We have our screening materials, we have our results, time frame, and of note, when we see possible atrial fibrillation, we repeat the testing to make sure that we see it again. Here's our Dear Doctor card. It's a two-sided card. On one side, we tell the physician what we did, what device we used, the results we found, and contact information, how they can contact us if they have questions. On the other side, we have the results in more layman terms. And importantly, one of the things we counsel our patients on is, get a hold of their doctor as soon as possible to discuss what results that we found today. Here's some of the materials we use. On the left-hand side is our patient handout. Again, this comes from American Heart Association. We download that. It also comes in Spanish language also, and we go through this. Every patient we see, we talk about stroke and AFib. So we think this alone is a valuable service. Middle one is, Joe mentioned understanding value of what we're doing. So we give patients postcards to fill out and send back to us. It's prepaid to get their assessment of what they think about this type of screening. And as Joe also mentioned, we have signage we pass out promoting our Know Your Heart, Know Your Rhythm program that we have. So as I mentioned, another opportunity, a great opportunity that we've took advantage on is our student-driven health fairs. And going to the community setting is a great way to really connect with the community. But there's a number of planning and other considerations when developing these events. One is, what kind of population do you want to target? Do you want it systematic or opportunistic? Got to think about advertising, local papers, signage, flyers. A lot of great places to do this. Community events, senior centers. We've done it at consulates, student unions, festivals. We were recently at the Lobo women's basketball game doing this. Very successful. Workplaces are great, including community pharmacies. You can promote screening day, and by doing so, not only are you providing a service to the community, but you're increasing your foot traffic into the pharmacies, which is also a good thing. It's important to designate a leader and make sure you get enough volunteers. Again, students are great to work with, and they actually can lead this. Want to make sure you have a good training plan, equipment, and remember, promote education. We're educating the public on atrial fibrillation and stroke. A lot of logistics. You got to have supplies, equipment, chairs, tables, sanitizers, swabs, pens, signage, forms, education materials. Now, as part of this program today, we've provided a checklist that we've developed and added onto to think about how to promote these community events, and you'll be able to download this after the presentation. Here are some pictures from our events. If you look in the lower right-hand side, this is at the Lobos women basketball game at the Pit. As you see, it's highly successful. We have blood pressure screening for diabetes, and AFib screenings, and the fans just loved it. If you look on the left-hand side, we've partnered with Nagasaki University in Japan, and is now doing this in Nagasaki Prefecture in Japan. And this was at a shopping mall actually it was a couple of years ago now that we did this, and we're going to go back in October and repeat this. Very exciting. So Joe mentioned this earlier, for these programs to be successful, people have to feel that there's a value to this. When we look at patient value, there's 2 studies in community pharmacies and 1 health fair screening study that nearly 100% of patients were very satisfied or somewhat satisfied with the screening, and they thought, importantly, that the screenings were worth their time and were important. When we look at pharmacist perception, high value professionally, and they also feel it's a high value to pharmacy. And if you read some of those comments, it's a way to connect to customers and another way to patients, help patients, and another way to contribute back on and to serve the community. So we talked about screenings in pharmacies and health fairs. I know we've alluded to this earlier. What about screenings in the clinic setting? Ash, is this feasible? Can we do this? What are your thoughts?
Thanks for the question. Yeah, I think it's important. We've demonstrated that with the slides. 12-lead EKGs are often not done routinely, though, in the clinic. There's reimbursement challenges. If somebody's complaining of symptoms, you can always do a 12-lead EKG. And new onset or asymptomatic atrial fibrillation obviously can be missed, as we talked about. Only 50% of people feel when they're in atrial fibrillation. But this could possibly be circumvented if we screened in the waiting room. This would be a screening service, gratis to the patient with mobile devices while they're in the waiting room. I think it's probably important to establish a workflow pattern for every patient. Technology can be used. This can be done with an MA or a nursing or pharmacy student at the point of care of assessment for each patient, or patients can even self-screen. There's a possibility that some of them are downloadable apps, or some of them will have mobile devices that they're wearing, such as smartphones. And then obviously there's still pulse palpation that can be used, and that's probably done in a clinical examination anyways. So if atrial fibrillation is detected, 12-lead EKGs are appropriate at that time, and then laboratory testing that can be ordered by the clinician, such as thyroid testing, probably some chemistries as well. And then confirmation is very important. So if it's screened in the pharmacy or in the waiting room, it's going to have to be confirmed. And then we're going to talk about in the next couple slides here, Barry, about anticoagulation and appropriate therapies. And then finally referring to an anticoagulation clinic.
So we've talked a lot about screening by, pharmacies, by clinics, by students, by health professionals. Joe, can patients just screen themselves?
Yeah, absolutely, Barry, they can. And we've talked about all the different devices that are now available. And they're available not just for healthcare providers, but for the general public. And so we know that, the general public has these smartwatches. There's blood pressure devices that can sense irregular rhythms. There's, of course, the handheld ECG devices that now are being marketed to individuals. So yes, they can screen. They can even do their own self-pulse check. They can be educated in how to do that. But what's important for us as healthcare professionals to know is that these devices are out there. And it's really important for us to educate our patients and the population that these are just screening devices, and educate the patients in the population about what is atrial fibrillation and what are the risks associated with it, and that they should seek out confirmation of the diagnosis with a primary care provider or a specialist. And so, that's a critical piece, I think, in terms of following up with these patients who may be screening for themselves.
There appears to be a tremendous opportunity to screen to engage patients with atrial fibrillation, it seems like. When patients do present with atrial fibrillation, we have to treat them. What should we as healthcare practitioners think about in regards to treating atrial fibrillation, Ash?
Thanks for the question. We'll briefly talk about treatment here. So atrial fibrillation treatment, we talked about why it's important to treat. There's a 5-fold increase in the risk of stroke, systemic embolisms, both in men and women. So all atrial fibrillations must be assessed. So after they screen at the community pharmacy or at a health fair, then they're confirm their diagnosis by seeing a clinician or practitioner. We talk about 3 parts of atrial fibrillation treatment: rate control, how fast or slow the heart rate is; rhythm control, whether it's atrial fibrillation or normal sinus rhythm; and then finally stroke prevention, which is probably the most important because not only does it cause mortality, but incredible morbidity as well. And the way we look at that is we have scoring systems for stroke risk. Everybody doesn't have the same stroke risk. I told you all that I had atrial fibrillation when I was in medical school. It was a one-time event. It never came back. And my CHAD score, or CHAD's vascular score, was 0, which meant that my risk for having a stroke or systemic embolism was same as the normal population. So I didn't get any anticoagulation at that time. But there's 2 scoring systems that we use, the CHADS-2 system or the CHADS-2 vascular system. We'll look at that in a little bit more detail. But all use selected clinical characteristics to predict a risk of stroke, and all the scores provide a rough estimate of the risk of thrombosis or stroke in a population at similar risk as the patient being reviewed. So what that looks like is this. This is the following. This is combining both the CHADS-2 as well as the CHADS vascular score. So you can see these risks increase your risk of stroke or systemic embolism. If you have congestive heart failure with LV dysfunction, either an EF of less than 40% or class 2 heart failure or worse, hypertension, age greater than 75, diabetes, or stroke. Stroke gives you a score of 2. We've extended that to a CHADS vascular scoring system that adds vascular disease, prior myocardial infarction, peripheral artery disease, or aortic plaque, a slightly lower age group there with a lower score, and then gender. The sex category is pretty important. Remember, we did look at the risk of women versus men developing stroke or systemic embolism. The female gender has a higher preponderance if they have atrial fibrillation developing stroke or systemic embolism, which is why there's an added point there. And so what that looks like from a guidelines perspective is in 2019, the American Heart Association, American College of Cardiology, and the Heart Rhythm Society had an update to the AFib management guidelines. So it's a class 1, A or B, to treat atrial fibrillation with an anticoagulant. 2 or greater for men, or 3 or greater for women. And these are the anticoagulants that are recommended: warfarin, dabigatran, rivaroxaban, apixaban, and edoxaban. But all anticoagulants aren't equal. And over time, we've had further data that shows that some anticoagulants are better than other anticoagulants. It's taken a while to collect this data. The true workhorse forever has been Coumadin or warfarin. And this is a comparison of the efficacy and safety of new oral anticoagulants or the NOACs, novel oral anticoagulants, with warfarin in patients with AFib. These are meta-analyses of randomized trials. And a lot of the comparisons of the NOACs versus warfarin cross the line of unity, but we see a lot of safety in the NOACs. We can see a significant decrease in intracranial hemorrhage as well as hemorrhagic stroke when we're looking at the NOACs compared to warfarin. And so what that looks like from a guideline perspective is now it's a class 1A to consider NOACs. The dabigatran, rivaroxaban, apixaban, and doxaban are recommended over warfarin in patients that are eligible with atrial fibrillation. And remember, this is all non-valvular atrial fibrillation. And valvular atrial fibrillation would be those that have moderate to severe mitral stenosis or a mechanical valve. And those patients still have an indication for treatment with anticoagulation, but with warfarin instead of one of the novel oral anticoagulants. When we give a patient an anticoagulant, we worry about two things. One, we want to thin their blood, as we say, to make sure that we reduce their chance of stroke or systemic embolism, but we don't want to overly thin their blood so they have bleeding. So we have a scoring system we call HAS-BLED here, and you can just read the risk factors there. For those that practice medicine and the pharmacists out there, this doesn't seem very unusual that these risk factors would increase your chances of bleeding. So hypertension, abnormal kidney or liver function, previous stroke, bleeding tendencies, having a previous history of labile INR, older age, concomitant drugs that actually have issues with bleeding as well, like NSAIDs, alcohol. All of this can be tabulated to a score, and those with the greatest score bleed more. Those with the score of 0 to 2 indicate a pretty low risk of bleeding, but greater than 3 indicates a risk for bleeding that's increased, and that increases as that score increases as well. So what we really need to do is weigh the need for anticoagulation, likely with a novel oral anticoagulant for those with non-valvular AFib, and balance that with this HAS-BLED score. The important part is we really should treat these patients that are at higher risk.
So, as you've pointed out nicely, there's a lot to consider when we're managing patients with atrial fibrillation, including risk factors and pharmacotherapeutic considerations. Ash, how do we approach a patient-centered care approach from an interdisciplinary team perspective?
Thanks for the question, Barry. You know, I think what we've demonstrated between Joe, Barry, and myself, that atrial fibrillation is going to be found in multiple settings. It can be found at a health fair. It could be found in an intensive care unit. It could be found in cardiac rehab. So the way we're actually working now is there's a lot of disparate care. In the right panel, you can see that the patient with atrial fibrillation is kind of floating around to these different clinics, whether it's electrophysiology, primary care, community pharmacy. They're even many times actually diagnosed in sleep clinic or at their sleep study because they have ongoing EKG throughout the night. So we need to replace this with a more coordinated care. So while the diagnosis, or at least the screening of atrial fibrillation may occur in many settings, and it will begin with the patient, we should have a more coordinated level of care between the patient and the clinical settings. And those clinical settings are going to have to also be linked up with treatment settings, as well as our community pharmacies to dispense those medications and, follow those patients as well. If the screening happened at a community pharmacy, Joe and Barry are our pharmacists. I would think that that patient would be tied to that community pharmacy. And that pharmacy has some commitment to that patient as well. And I'm sure that the entire AFib community would benefit from that as well.
So Joe, and this integrative, multidisciplinary team approach is really important. It involves many different type of services and professionals. Where do you see us, the pharmacists, having the greatest impact in this team setting?
Yeah, thanks, Barry. And as both you and Ash have alluded to previously, one of the roles of community pharmacists is just screening for atrial fibrillation. So, using those devices and providing the opportunistic or systematic screening. But also, really important role is just education. You touched on this earlier, Barry, but educating the patient about atrial fibrillation. What is it? If they're performing the screening at home, they've got their own smartwatch, informing them about the risks of atrial fibrillation and the importance of going and seeing their primary care provider for confirmation of the atrial fibrillation. And then educating the patient about the risk of stroke. What are the warning signs of stroke? And what should they do should they develop any of those warning signs? And then educating them, of course, about the medication treatments that Ash talked about, whether it be rhythm control, rate control, or anticoagulation. What are those therapies and why is it important to take those therapies? So that goes along with another key role, which would be monitoring for adherence to therapy and making sure the patients are adherent to that therapy.
I agree, Joe. It all begins with the patient. If that patient is educated, they'll have an idea of what that means, what the next steps are, and then when they're screened, and if they screen in, following up with their clinician to determine what therapies are necessary. There are times that anticoagulation is not necessary. It's not very common because atrial fibrillation is usually diagnosed in our older patients, and anticoagulation is needed. But also talking to your cardiologist or your primary care physician. There are some complex management issues that sometimes are necessary, but the first part is educating your patient, getting them diagnosed, and following up with their clinician.
As Ash and Joe have nicely discussed, we have to have an interdisciplinary team approach because atrial fibrillation is complex. Now, another critical aspect that you mentioned, Joe, is medication adherence. If patients don't take their medication, they're not going to prevent stroke associated with atrial fibrillation. Can you talk a little bit more about medication adherence, the importance of that in atrial fibrillation, and sort of how do we improve or general factors on approaches to medication adherence?
Yeah, absolutely. Thank you, Barry. And as you mentioned, if you're not taking your medication, it doesn't work. And it's really important with regard to anticoagulation therapy, for example, because the greatest risk with atrial fibrillation is stroke. And with proper anticoagulation therapy, we can reduce the risk of stroke anywhere from 40 to 80%, but you have to take the medication. And so studies, unfortunately, have shown that adherence rates with anticoagulation therapy vary, or I should say non-adherence rates vary from anywhere from 25% to 40%. And importantly, in those studies, they're showing that in those patients who are not adherent to their anticoagulant therapy, it does increase the risk of stroke and unfortunately the risk of death. And so very important to adhere to therapy. And when we talk about adherence, medication adherence, or really any medical adherence, it's really a complex condition, if you will. And so there's a multitude of factors, many times multiple factors within one given patient. And this slide goes over several of those potential factors for non-adherence, such as social and economic factors. Sometimes, patients have low health literacy levels, and so they may not be able to understand why they're taking a particular medication or how to take a particular medication. Insurance sometimes, if they don't have proper insurance, they may not be able to afford the newer anticoagulation medications, or they may not be able to afford transportation to get to their clinic appointments. There are healthcare system factors. Studies show that if patients perceive a trusting relationship between themselves and their providers, they're more apt to adhere to therapy. They're more apt to come to their appointments. And so proper communication plays a key role in improving adherence. There's condition-related factors. We just talked about asymptomatic, how atrial fibrillation is many times asymptomatic. Well, if you're asymptomatic and now you're asked to take a medication that has possible adverse effects and side effects, you may not be convinced of the need to take that medication. So once again, going back to the importance of communication with that and education with that patient. And so there again are a multitude of factors, sometimes physical factors, vision impairment, swallowing difficulties, trying to give them a formulation of the medication that they can take. And then there may be some psychological factors involved as well. Not perceived, they don't perceive the risk of the condition to be or to exceed the risk of taking a medication. They may have seen on the internet that this medication can cause side effects. They may have seen commercials from lawyers asking them to call them if they've taken a particular medication. So naturally, they have an anxiety about taking that particular medication. So again, we have to overcome those concerns with education and communication with the patient. And how do we overcome non-adherence? And as I mentioned, talk to the patient. So really key is patient education. Ash mentioned it earlier. Really talking to them about what the risks are with atrial fibrillation and how we can reduce those risks with proper treatment. And really, there are a multitude of ways to communicate now. We talked about technology from a patient perspective of being able to screen for atrial fibrillation. Well, now we have technology to communicate with patients. We can send text messages to them to say, hey, time to come pick up your medication. We notice you're late a couple of days. Come on in and get your medication refill. So there's those sorts of technologies. There are pill boxes, simple pill boxes. They've been around for years, but vitally important. Ash mentioned earlier how he had atrial fibrillation, and fortunately he did not have to take anticoagulation therapy. I've had illnesses, and unfortunately I can't follow through on my therapy. I can't remember to take it. So I have to have a pill box myself to remind myself to take medications. And so I think it's really important. And when you introduce other disease states and other medication therapies, it builds in terms of the ability to adhere to therapy. And so very important to implement pill boxes or blister packs are great things. You can get as advanced as digital dispensers. There's mobile apps now. You can educate your patients about what is a good app to utilize to remind yourself to take your medications. The smartwatches have built-in reminders and apps that they can use. And then many pharmacies are using automated phone calls for adherence and refill reminders. Continuing on with other approaches to improve adherence. We talked about the different settings of pharmacists. Pharmacists in the hospital settings are key for medication reconciliation. If a patient is diagnosed with atrial fibrillation in the hospital, now they have new medications that are being added as they're being discharged. So what medications are they to continue upon discharge to their home, and what medications are they to discontinue? And so that's medication reconciliation, and that's an important role for really all providers to make sure that the patients are taking the appropriate medications they're supposed to. Simplifying medication regimens can help a great deal. Once daily dosing of medications, many formulations now are available that are once daily. Obviously, adherence improves with once daily medications versus twice or 3 times daily dosing. But really, telling the patient, what medications can they take at the same time if they are taking multiple times a day medications. 90-day supplies can decrease the transportation issues, for example, of coming into the pharmacy once a month. Automatic refills, where you time all their medications to refill at the same time so that they're not having to come back multiple times a month to get medications. There's adherence packaging, as I mentioned. Those are things like the blister packaging, where all their medications are packaged in a blister pack so that they would take all their morning meds at once, all their evening or afternoon meds at once. These can all be helpful. Looking for ways to reduce cost. Sometimes if cost is an issue for a particular patient, are there coupons that are available? Are there manufacturer programs in which the patient can be placed into to decrease cost? And of course, talking to them about adverse effects, what to look for, and to notify you and or their primary care provider should they have any of those adverse effects.
Joe, Ash, that was a great overview. We talked about screening, we talked about diagnosing, we talked about treatment, the rationale for screening, why we should do that, the concerns with asymptomatic atrial fibrillation, and importantly, not only treatment, but also importantly, improving medication adherence in patients taking anticoagulants for atrial fibrillation. Now, as both you and Ash clearly point out, we have to work collaboratively with our clinical colleagues to really move patients through the system and bridge the gap between patients and all members of the healthcare team to improve the screening, the diagnosis, and importantly, the treatment. And again, we can't emphasize enough, especially in pharmacists, medication adherence. So before we conclude the program, make sure you review and download the resources that we've provided. Please feel free to share. We think this is important, and we like to, we're more than happy to have this disseminated out to other healthcare practitioners to help with screening and managing atrial fibrillation. And with that, that ends our discussion for today. Again, thank you again, Joe and Ash. Great insights today. We all hope you found this activity informative and useful to your practice. And again, thank you for participating today.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/KMF860. This activity is supported by an educational grant from the Bristol-Myers Squibb and Pfizer Alliance. This activity is certified by PVI, Peerview Institute for Medical Education.